Happen. Look, there's one more way.
May I request each one of you to kindly keep your mic on mute so that all of us have experience of the lecture.
Okay.
சத்குரு பத்தி என்ன சொல்றாரு அவரு? You're on mute.
My apologies. Hope I'm audible now. Thank you, Steve, for bringing that notice. Once again, very good evening to each one of you. May I just request if all of you can keep yourself on mute so that all of us have an equally good experience of hearing what Steve have to share and celebrate World Physiotherapy Day together. Thank you so much. Just think that I'm keeping everybody on mute to begin with. Yes. So I, Nitesh Bansal, Honorary Secretary of Society of Indian Physiotherapists, on behalf of all the founder members and the governing body members, wish each one of you a very happy World Physiotherapy Day. I once again welcome you all for this 5th World Physiotherapy Day lecture to be delivered by none other than Professor Steve Milanese. Professor Steve Milanese is a name which usually doesn't need an introduction, but to do the customary procedures, I would like to introduce Professor Steve Milanese, who would be talking about knee injuries on field today with us, sharing his experience, vast experience of sports physiotherapy spread over a decade, probably like 3 decades and numerous publications. He's currently with Curtin University and University of he did his doctorate from Curtin and currently engaged with University of Tasmania and has a lot to share with us. Over to you, Professor Steve.
Thank you very much for that, Professor. I'll just share my screen. Let's have a look. Okay, cool. So I'd like, first of all, very much to thank the Society for inviting me to give a talk in an area of interest of mine. I've been coming to India now for well over 10 years looking back, and I've been really have a lot of respect for the standard of physio in India, and look forward to continuing my relationship with the Society. I also, part of my role is as the current chair of the International Standards Committee of IFOMT as part of the World Physio, and I look forward to the Society becoming a member of IFOMT. So very much hoped to see the Society of Indian Physios actually starting to get some programs accredited with our International Federation of Orthopaedic and Manipulative Physical Therapists. So today, though, what I'm going to do is talk about evidence-based clinical reasoning in an on-field knee injury. So we're looking very much at the an acute athletic injury and looking at the evidence associated with it and putting it within the clinical reasoning framework. I very much look forward to the opportunity to answer any questions at the end of this talk as we go through. The aim of the presentation to begin with was very much to explore the current research or to present the current research evidence associated with the on-field assessment of the injured knee in a sports physio context. That was the original aim of the presentation. As I've gone through, it's been an interesting adventure in looking at some of the issues associated with the evidence that we see presented in this area. And hopefully, as we talk through in the next 45 minutes, you'll see some of the pitfalls in this area that we can all learn from, I think. I'm also an academic, so currently I'm at the University of Tasmania as the academic lead for the physiotherapy program. I'm also a professor at Swinburne University in Melbourne. So, but as an academic, I like to define things. So let's look at the definition associated with the title for today's talk. So looking at evidence-based practice, I'm sure you're all very aware of it. It's that the classic definition from Sackett et al. Is for evidence-based practice or evidence-based medicine is the explicit, conscientious, and judicious attempt to find the best possible available research evidence to assist us to make the best decisions for our individual clients. And the three key words, I think, in the use of evidence into clinical practice, and this became very evident during this review, and we'll talk about as we go through, is it has to be explicit and conscientious. We need to be really transparent and rigorous in our approach in the use of evidence in clinical reasoning in any intervention that we're looking at bringing into practice. So, and that's particularly important in this time of the physiotherapy putting its mark across the world in different health systems. We're really fighting for greater recognition in every country I've been to. And I think that's, we need, when we're going to put evidence-based practice into our clinical practice, we're very explicit about it. We're conscientious about it. We're also judicious in that we make sure that when we use evidence in clinical practice, we're doing it in the context of clinical experience, the patient's values, and the context in which the evidence is going to be used, that the treatment's going to be utilised in. And that's particularly important when we're looking at the on-field knee injury management, which we're going to talk about today. Clinical reasoning is a particular area of interest of mine from a research perspective, and it's an interesting. I find it a particularly interesting area because we still know so little about it. I like this definition for clinical reasoning. It's one that I'm particularly enamored with because it really gives you the broad spectrum. Because it's a continuum. At one end is a strongly embedded scientific analytical approach that's strongly within the evidence-based practice approach, talking about hypothesis testing, systematic sorting of clinical data, etc. So Bayesian reasoning and more high-level clinical reasoning using evidence-based practice, through to a more intuitive process that doesn't really resemble this scientific method. And what we see more and more is, I think in clinical reasoning, is there's still this intuitive process that I don't think we really understand yet. And that's, like I said, a particular area of interest of mine from a research perspective. And when we look at it, and this goes not just in physio, this is also in medical education. When we look at the literature in its most broadest sense, is we still lack a definitive definition of what clinical reasoning is. So if we're going to try to look at evidence-based clinical reasoning, we really need to kind of get a context of what we mean by clinical reasoning. This, and it's been written by a number of authors, this lack of a concept of clinical reasoning means it's actually difficult from a teaching, assessment, and research perspective. From a personal perspective, having taught in 5 universities in Australia, each university teaches or uses clinical reasoning and assesses it slightly different. So I find it's, I think from a student perspective, it makes it very difficult if we're not really clear cut on what clinical reasoning is. And that's aim of my particular area of interest in research. I break clinical reasoning down into a very simplified model. I'm not smart enough to be too complicated. So I look at clinical reasoning as being a black box with antecedents, the input that come into that, and consequences, the outputs that come out of it. Oop, the audio is not clear. Hopefully I'll slow down and see whether that helps. So our clinical reasoning, there's discussion of whether it's hypothetical deductive, pattern recognition, narrative reasoning, clinical prediction rules, Bayesian reasoning. There's a number of different models of clinical reasoning that's involved. So the model that I'm working on developing in clinical reasoning, we use this in our teaching, is to look at the things that we put into the clinical reasoning, information that we need, and that will range from the examination, which is the referral information, our observations, the subjective, objective examination, investigations, etc., the environment or the context in which case that reasoning is occurring, the knowledge that's involved as well. So the evidence, the scholarly activity, the experience of the practitioner, and the attitude of the practitioner as well. And from the output, the decisions we need to make clinically are things such as narrative decisions, understanding the patient's perspective, predictive decisions, understanding prognosis of the patient's presentation, the management, and the diagnosis are probably the main clinical decisions we need to make. So really wanting to set this as a framework by which we're going to look at clinical reasoning in an on-field knee injury. Now, sports physiotherapy is quite unique. I think it's a really unique area when we look at clinical reasoning because we have three quite unique situations in which we need to reason and think about what we're doing with our patients. And that is the on-field assessment, where we're actually on the field from a sports physio perspective, the on-field knee injury, it's just occurred. We're often the first ones on the scene. The sideline assessment, so the athlete who's then able to come off the field and then we assess them within on the sideline, through to your traditional clinical assessment, which is a standard part of musculoskeletal assessment. So we have three unique contexts in which we clinically reason with knee injuries in sports physio. And when we look at the traditional look at clinical reasoning, when we talk about fast thinking and slow thinking. So fast thinking is where you come in with a clinical pattern in your head already, and you're just trying to prove it. On-field assessment is very much dependent on that fast thinking model. We need to look at the clues early on, and we'll talk about this as we go through, to develop the clinical patterns before we even touch the patient, because we'll already have some hypothesis formed in our heads and it's really proved to disprove at that point. Our sideline assessment is a little bit more. We're allowed more time for slow thinking. And our clinical assessment is one where we go right from fast thinking through to slow thinking. So slow thinking is your hypothetico-deductive reasoning, where we're developing hypothesis in our assessment and we're asking lots of questions. We're proving and disproving various hypotheses as we go through. Fast thinking is that quick. We come in with a clinical pattern from the key points and we try to prove or disprove those clinical patterns. So when we talk about the on-field assessment, the uniqueness about it is you only have 5 minutes. You're out in the field. And depending on the sport, depending on whether you can run straight out or whether you have to be called by the referee, but you're out in the middle of the field. You've got, if you look at soccer, you've got 22 eyes, that's 21 other players and the referee looking at you. And your clinical decision at that point with your injured athlete is, can the player continue to play safely? We don't have the ability to do full assessments. So we have to come in with a preconceived idea, a pattern in our head as far as what's going on, so we can make that decision. So it's very much a fast thinking type approach in our clinical reasoning. So if we look at the decisions that need to be made, the decision has to be, can the player continue to play safely? At the end of the day, when we're on the field, that's the decision we need to make in that first 5 minutes. If yes, if it's very clear, and we're going to talk about this with the evidence associated with various injuries, if it's okay for them to play, we can then get them to continue to play, but we need to make sure we monitor them. So with any knee injury, particularly when we look at meniscal tears, that they may actually present the locking, or if you've got a bucket handle tear, may actually present later on during the game. So with someone where there is a clinical suspicion of a meniscal injury, but no significant symptoms, and they're able to full range of movement, weight bear, run, etc., we still monitor the athlete for the rest of that game. So they have extra monitoring, if you like. If we don't think the player can continue to play safely from the mechanism of from the extent of the injury that's going on, then we need to make the decision, can you move the player safely? And that will be yes, then we'll do it with assistance or by stretcher, or if no, if we're thinking there's a significant fracture or there's a medical emergency. And that's, again, the on-field assessment is often more than just looking at the joint, because sometimes that could be a byproduct of other medical type issues we need to be aware of. So if we can't move the player safely from either a medical scenario or a significant fracture, then obviously we call the ambulance or provide first aid. So that's really the on-field range. It's a very unique form of assessment for a physio, and that's where the sports physio clinical reasoning occurs in a very sharp, quick way. In the sideline assessment, you've got 10 to 15 minutes. So athletes pulled off the game, they're on the sideline. You get a chance to do more of an assessment. You're still limited. There is still a game going on, and you're still the physio for that team. So from a sports physio perspective, you have a bit more time, but you don't have the luxury of a full clinical assessment. In this scenario, in the sideline assessment, our clinical decision is, what's the diagnosis? We can explore the diagnosis more. In some sports, you may allow the player back on the field if you reflect that the injury is not as bad as first thought. Most commonly, you can't once they're off, in which case the diagnosis really drives into what's the early management. Do I need to refer this patient on? Do we use ice? Are they able to return to sport, etc.? What is the training they may need to do afterwards? So this is a combination of fast thinking and slow thinking in this area. And when I'm talking about on-field injury management, I'm going to focus on these two areas, the on-field and the sideline assessment. When we look at the evidence, the most common acute knee injuries, and the ones that I would most commonly see, would be anterior cruciate ligament injuries, significant injuries. And I'm not talking the minor contusion, the player can just run back on the field. These are significant injuries that we need to examine and get them off the field. Meniscal injuries, fractures, and medial collateral ligament injuries. And the extent of these four, the relative prevalence of this four, will depend on the sport. In some sports, the incidence of anterior cruciate ligament injuries is significantly high. We find a lot of female football codes now, particularly in Australian rules, but also soccer, football, that with more female athletes playing, there's a higher incidence of anterior cruciate ligament ruptures. Whereas in other codes, in football codes, etc., there's a higher range of medial collateral and meniscal injuries. So again, it depends on the sport that's involved. We'll talk about that as we go through. So this is from a study that Majewski et al. Did in 2006. They followed 19,500 sports-related injuries in a clinic, an emergency clinic, over a 10-year period. ACLs were the highest, medial meniscus next, then lateral meniscus. And again, these are patients who could not continue to play. They're the ones we're more concerned about from a sports physio perspective, that on-field injury management. When we look at the clinical reasoning, what information we have for these acute on-field injury management, we have our observations, a most important part of our examination. The objective and subjective examination are limited. Our observations, probably the main part of examination information that will come through into the clinical reasoning. We've talked about the environment. The knowledge, experiential knowledge, is really important. Experiential knowledge is your knowledge of the sport. By working in a sports club for a period of time, you get to develop an understanding of the types of injuries that you may see in that sport, the mechanism of injuries, the players, their history. So experience is a really important part of the knowledge that feeds into the clinical reasoning, as well as the evidence we'll talk about during today. And at the end of the day, as I said, the main clinical decision is diagnosis. When we look at the acute assessment, there is some good evidence, and this is from a series of 3 rapid review series on best practice management of acute knee injuries in ED. There's good evidence to support history taking in the examination of the acute knee trauma. And when we talk about history taking, we're talking about understanding the mechanism of injury. That's one of the key aspects when running out to a player or going out to a player on the field or on the sideline, is to understand the mechanism of injury. I'd say understanding it before you actually do the objective, because the mechanism of injury will give you an idea in your fast thinking of the clinical pattern that you're needing to look for. You want to look at the associated symptoms, the location, the characteristics of the pain, and the functional and medical history. And you'll know that if you work with a team for a period of time, those aspects. But really understanding the mechanism of injury is important for the clinical reasoning. So when we look at, this is from a summary of an evidence-based guideline for general practitioner diagnosis of acute knee injuries. If the player reports or you demonstrate a valgus type injury, and this may be from a tackling injury usually, so football codes or someone where they're tackled or struck from the lateral aspect of the knee, so there's a valgus type force, the foot's fixed, then, and the patient reports medial knee pain, has to be a strong suspicion of MCL tear prior to your assessment. So when you're going into your objective examination, so when you're on the field, you'll be assessing for that, given that history before you saw them. If they have a pivot or leap type injury, in particular the landing that goes into a forced hyperflexion or hyperextension type injury, the patient, in my experience, will often talk about, they say there's something broke in the knee, something's disrupted, something's not right, even if there's not a lot of pain associated with it. They have this sense of disruption. They know there's something wrong inside the knee. They can't put their finger on it, and that'll be in the first few minutes. By the time you come out to see them on the side, on the field, there's usually an audible pop. It's quite commonly an audible pop. They'll say they feel something snap, or they'll feel people have said they've actually heard the popping noise. What's classic is when you stand them up, they'll say the knee feels unstable. As soon as you have that, then you're talking about a potential ACL tear. So that history is really important. In this first 10 minutes, 15 minutes when you're on the sideline, you're unlikely to see significant rise in swelling, but generally within the hour, if it swells, then you know it's an ACL tear. Reason being that the ACL is the only structure with blood supply inside the knee. So if it bleeds within the first hour, if the knee joint swells within the first hour, it's diagnostic of an ACL tear. If when you're watching the player before they go down, there was a trivial twisting injury, maybe to do with cutting or twisting, changing directions, but it wasn't excessive, or it was an end rate squatting type activity, the patient may report giving way when it happens, so they fall down because there's a catch inside the knee. They may report locking and catching. These would suggest a meniscal type injury. So your assessment in that first 5 minutes is about meniscal testing. If they have a direct injury to the anterior tibia, forced hyperflexion or hyperextension, and when you're out, so your forced hyperextension and hyperflexion can be both an ACL or PCL. If when you go out to the athlete, they talk about, when you look at where they hold their knee, they put their hand behind the knee. My experience being with PCL ruptures is they usually have the pain posterior, deep posterior. The hand's on the front of the knee, it's generally an ACL tear with a hyperextension or hyperflexion injury. The other classic sign I found with PCL tears is that when they go from lying on their back over to their hands and knees to stand up, they are unable to take weight bear through the knee. So when they roll onto the knee and they load the tibial tubercle in a 4-point kneeling, is that they're unable to actually take that weight. They'll drop out of that position. As soon as you see that, that's classic for a PCL tear. So it suggests at that point that they're off. The PCLs don't tend to have the same level of instability as the ACLs do, in my experience, so they can often go missed. but these are significant history findings from them. So we go in to these two assessments, the on-field injury management, with a strong suspicion, a pre-testing probability based on the history area of symptoms, the history of injury, the type of injury, the mechanism of injury, and the area of symptoms. We then rest on clinical tests. Our assessment then is strongly based. Remembering it's a unique environment. This is straight after the injury. What I found in my review, and I've been looking at this for a while, is that there's absolutely no evidence associated with on-field assessment. Every time we've looked at the when I've looked at the acute injury stuff, it's all within a 4-day, judging within a 4-day period is considered acute assessment of the knee. The problem for an ACL or even a meniscus is the knee has swollen by then. So we're not going to get the same diagnostic accuracy as we would when the knee joint was not swollen. And we're going to explore that a little bit more as we go through the evidence. Let's look at some of the research evidence. Tanaka et al. In 2022 released a very nice systematic review, meta-analysis, to establish the diagnostic accuracy of 4 physical examination tests for acute ACL injury, particularly in the post-injury phase, so in the acute ED phase, so within 4 days. They found 8 studies, so about n equals 620 studies. Nicely to see in the evidence that they presented was it was a low or moderate risk of bias and a low concern about applicability. So the evidence was had a low risk of bias and was more likely to be applicable to answer the question of diagnostic accuracy. 3 of the tests that they reported with reasonable results were the traditional Lockman's test, the one on the left, which I'm sure you all know, which is looking at the anterior draw of the tibia at 30 degrees flexion. We have the anterior draw test at 90 degrees flexion and the lever sign test. The lever sign test is where you put your fist underneath the proximal tibia, you push down on the distal femur in an intact ACL. As soon as you push down on the femur, the heel will raise off the bed. With an ACL rupture, a positive lever sign is that there's a lag that as you push down on the femur before the ankle actually rises, and that reflects the anterior translation of the tibia on the femur, reflective of a ruptured ACL. The other test they did with the pivot shift test, but that didn't come up very good on the testing, so we're not going to look at that. I'm going to focus on these 3. When we look at the Lockman's test, this is from the meta-analysis, we show the sensitivity of 0.79. So if the Lockman's test is positive, there's a 79% chance of a ruptured ACL. That's fairly high. So it's a fairly good test in the acute scenario. What intrigued me when we look at this meta-analysis is those 2 studies, which are on the left-hand side of the forest plot there. And this was Mulligan 2017 and Kayak in 2018. And it struck me as interesting about why those 2 studies were so poor. And what they've done is drag the sensitivity down. When we look at the remaining sensitivities, they're actually really high. Kayak did theirs pre and post aspiration, and the study meta-analysis only used the pre-aspiration data. So they only used the data when the knee was fully swollen. And that's not reflective of what we would see in the acute knee injury, in that on-field injury management. There may be development starting to, the knee may start to fill with hemarthrosis, but it's unlikely to be as full as it would be within the hour. So really the post-aspiration or the sensitivity figures where there is less fluid in the knee are a more accurate one. And when we see that, the 0.68 with a range from 0.5 to 0.81, that's more reflective of the other data. The other study, the Mulligan 2017, I found interesting because the actual data on the supine Lockman's test is different than it's reported in the meta-analysis. It's actually 0.67, again, reflecting more commonly what the other studies were reporting. So we would have to say when we're looking at the Lockman's test for meta-analysis, when I redid the numbers, it's a late 0.84, 0.85. So about 85% chance of a ruptured ACL if the Lachman's test is positive. So higher than was reported there. So it's a good test in the acute stage. Specificity, there's a 78% chance that the Lachman's test, if the Lachman's test is negative, there's a 78% chance that the ACL is intact. So again, relatively good from a specificity perspective. But again, we look at the data of some of the lower studies, again, Mulligan's 27, we see that the actual results in the Mulligan's paper is actually a lot higher than that was reported in this meta-analysis. So again, be really clear when you're reading evidence reviews to maybe go back to the original data every now and then for things that don't look right, because those studies look lower than expected. So it would make the specificity higher than 0.78. My guess it'll be about 0.82. So about 82% chance of an intact ACL if your Lachman's test is negative. Overall, your positive likelihood ratio, 7.36, meaning that someone who tests positive to Lachman's test is 7.36 times more likely to have a ruptured ACL compared to someone who tests negative. So it includes both sensitivity and specificity. Again, the data that's reported for Mulligan of 1.35, positive likelihood ratio actually was 24 in the paper with a supine Lachman's test. So we see that the data was a lot higher, a lot lower reported in the meta-analysis. So really important, again, just to ensure that if something doesn't look right, that now with open access, you can go back and read the papers and look at them. So there's a higher likelihood ratio than just 7.36. The anterior jaw sensitivity of 78%. Again, when we look at pre-aspiration and post-aspiration, the post-aspiration number improves. So our anterior jaw test is better with no swelling in it, which is what we would expect to see in the acute scenario. Specificity, if the anterior jaw test is negative, there's a 91% chance of an intact ACL. So we see when we compare the two, the Lachman's is better from a sensitivity perspective. The anterior jaw is better from a specificity perspective. So we really should look at both tests to prove or disprove the potential for an ACL rupture. Positive likelihood ratio, get about 6.7 times. So overall, not as good as the Lachman's test. The lever sign looked slightly better from a sensitivity perspective. So the lever sign test appeared to be slightly better identifying a positive test, a positive ruptured ACL than the Lachman's test. And I think primarily because a patient can relax easier while doing a lever sign test than they can with a supine Lachman's test. And if it's negative, there's an 88% chance of an intact ACL. We see a number of tests there with relatively good sensitivity and specificity related to the risk of an ACL and identifying an ACL rupture or tear. Oops. When we look at the meniscal injuries, so we see that Smoke et al. Did a review of all meta-analyses and systematic reviews. So there's so much data being published now that between 2009 and 2019, they managed to identify 142 systematic reviews looking at the diagnostic accuracy of, or systematic reviews looking at meniscal injuries, of which 15 related to diagnostic accuracy. What we see with the McMurray's test, a sensitivity of about 61 to 70%, so a positive McMurray's test, you're about 65% likely to have a meniscal tear if your McMurray's test is positive. The Thales test is a better test at 75%. So there's a higher sensitivity associated with Thales test than there is for the McMurray's. And joint line tenderness had quite a significant range associated with it. So of the three, Thales is going to be the most accurate to test positive, and McMurray's in the traditional McMurray's test has a fair to moderate diagnostic sensitivity related to a positive result. When we look at the McMurray's test, it's an interesting review from King et al. In 2013, which looked at 11 studies with about 1,500 participants, found that the actual McMurray's test, whilst it had a higher sensitivity, a relatively high specificity for a lower sensitivity, actually, when you did a modified McMurray's test, it was more accurate than the traditional McMurray test in their meta-analysis. The modified test in McMurray's is the addition of the varus and valgus associated with the testing. So it's to do a varus and valgus when you're actually doing the rotation of the tibia on the fixed femur into full flexion. Adding the varus and valgus, which are a modified McMurray's test, allows for greater sensitivity and greater specificity associated with the testing. So important finding when using meniscus is that we actually do add that varus and valgus force as well to improve the diagnostic accuracy. Brady and Wise extended rather than just looking at specific tests. Brady and Wise in their study, this reflects what we found, what we reported early on, is the need for other information to add to the diagnostic strength of the testing. This becomes particularly important in the acute environment. So they looked at clinical examination. And their clinical examination, the clinical criteria was pain in the knee joint, locking, joint line tenderness, giving way, reports of giving way, and a positive modified McMurray's test. So you needed, I think, 3 out of the 5 to be tested positive. So pain, locking, joint line tenderness, giving way, or positive McMurray's test. But they found that it had reasonable accuracy, so sensitivity range of 85 to 94%. So we can see from just doing a purely McMurray's, we're talking about a 65% accuracy. We can up that to an 85 to 94% by understanding the mechanism of injury and looking for those other signs which add together, things such as joint line tenderness, locking, giving way. Lateral meniscus was slightly reduced. The issue is the specificity was not great for either of them. So the ability for those testings to be negative, if they're negative for them not to have a meniscal injury, was not as high. Imaging study with the Thales test. So the Thales test, for those who don't know, is with the foot fixed on the ground. You hold the patient's hand, and it's reportedly to be done in 2 positions, 20 degrees flexion and 5 degrees flexion. The evidence suggests from a systematic review, is that when done at 20 degrees, so what happens is the patient twists into on that knee medial and lateral rotation, so they twist their body to the sides. You can see at 20 degrees we have a higher accuracy, both in sensitivity and specificity, for both the medial and lateral meniscus, than we do at 5 degrees. So it was when doing the Thales test is best done, particularly in the acute stage. This would be a sideline test in that 20 degrees flexion rather than towards 5 degrees flexion, which was the original report and how the test was done. Okay, the other thing that from a safety perspective is really looking at the acute knee fractures, which we need to be aware of, and really the real guide, the gold standard for the identification of acute knee fractures is and remains the Ottawa Knee Rule. And this was developed in 1995 by Steele et al. And it requires at least 2 or more of these to be positive. Patient at least 55 years of age, unable to weight bear immediately after the trauma, and in the ED, so within an hour, for at least 4 steps, and that's regardless of where they're limping, their ability to actually weight bear. If they have isolated patellar tenderness, significant tenderness in the patella, which is isolated from all the other structures in the knee, isolated fibula head tenderness, and they're unable to flex the knee to 90 degrees, then that suggests a risk of a fracture. When we look at SIMS, did a systematic review of meta-analysis to establish the diagnostic accuracy in assessing acute knee injury in adults. So again, this was really looking at knee injuries in the acute scenario. Sideline, they looked at 8 studies with 7,300 participants. Again, good evidence as far as the quality, low risk of bias, and no concerns about applicability. It's good. So it's relatively reasonable to accept this evidence in practice. What they found, the sensitivity is about 0.99. So if the Ottawa Knee Rule was positive, there's a 99% chance of a fracture. Specificity, 0.59. So if it's negative, there's a 49% chance of no fracture. So a negative OKR does not rule the patient out. So really important, we'll include this in our acute knee assessment, but if it's clear, it doesn't mean they don't have a fracture. They still need to be monitored as they go through. Positive likelihood ratio of 1.86, which is not too bad, nearly twice the odds. Okay, so I just want to summarize what we've talked about up to date, and that's trying to bring that evidence into how do we assess the patient on the field. So what I found from the evidence was there was very little evidence of on-field assessment, sorry. So everything was within 4 days in the ED department where the evidence is being developed. First thing is you really need to focus on the mechanism of injury. So at the point of injury, if you're on the sideline, if you're a physio in the acute scenario, you're working with the team, you're being called out for a player that's down. If you haven't seen it, ask someone, have they seen the injury? What was the type of mechanism of injury? When you get to the player, ask them what happened. The mechanism of injury is really important. At that point there, you would develop your clinical reasoning, your fast reasoning pattern to be able to then do your observations and your movement. So observe how the knee is being held. Ask about the area of type of symptoms. We've talked about the fact that they may have deep inside knee, which suggests ACL. If it's posterior, it's more likely to be PCL. Obviously, MCL over the medial aspect of the knee joint. Move the knee 90 degrees. So move the knee and see if you can get past 90 degrees, then we're now coming out of the Ottawa Knee Rules. It's unlikely to be a significant fracture or significant pathology. Palpate along the joint line, particularly for a meniscal injury, to assess whether it's above or below the joint line. If it's above or below, particularly on the medial side, it's an MCL, maybe an LCL if it's on the lateral side. Get them up and see whether they're able to weight bear. If they're unable to weight bear, then we need to think about, is it a fracture? Again, part of the Ottawa Knee Rule. Or if the patient is unable to weight bear, not from pain, but because it feels really unstable, then we need to really consider an ACL. Either way, they're coming off. Or if they're unable to straighten the knee, there's a lock, a mechanical block to knee extension, then we're talking about potential bucket handle tear, which leads to a potential meniscal injury, or if there's significant pain on the medial side, it's more likely to be an MCL as they straighten their knee. Remembering that 30-degree flexion is a loose packed position for the knee joint, so all the ligaments are off stretch. Once you extend, the MCL stretched. So if there's any pain, it's more likely to be related to the MCL. And are they able to walk? Normal strike or something that's not a significant ligament damage will generally be able, in my experience, be able to weight bear. They'll be able to walk 4 or 5 steps around, and what they'll find is the symptoms start to ease off. That's a good sign that they can continue to play safely. If it doesn't in those 4 or 5 steps, or they have a feeling of instability, if there's locking, etc., then they come off. They then come into the sideline assessment. Remember, we have a little bit more time in this environment. We really follow up on the mechanism of injury, confirm it. We're going to do more observation. By now, it's 10 minutes after the injury. If we're noticing swelling on the medial side, it's more likely to be an MCL injury. If we notice the knee joint starting to swell, then it's more likely, and the early stages, will be palpation in the posterior popliteal fossa. So I would normally have the patient lying down. If I have a suspicion of an ACL, I will be palpating in the posterior aspect of the popliteal fossa bilaterally. If you're feeling thickening on the injured side, that's often an indicator with the knee straight that you're starting to get swelling. Hemarthrosis. you're starting to get blood into the joint. With the knee straight, you tighten all the ligaments. The only place for the swelling or the blood to go is posteriorly into the popliteal fossa. So that's a really sensitive way of identifying early swelling. If you have that, then again, you know it's an ACL rupture or a significant tear. Ask about area type of symptoms, as we did before. Check their range of movement, look at their palpation, make sure they can weight bear. You'll already have got them on the sideline, so you'll know their weight bearing status, and then perform the relevant clinical tests. ACL, I would normally recommend a lever sign and then a Lockman's. Personally, in the acute scenario, I do Lockman's as a posterior, a prone technique, as we see in the picture there, where you palpate the tibial plateau and femoral condyles anteriorly, and you're putting a pressure, the knees at 30 degrees flexion, and you're putting a pressure directly down at right angles to the tibia, and you're feeling the anterior movement. My experience has been a patient in this position is more likely to relax than doing the anterior, the traditional supine Lockman's. And I think both lever sign and Lockman's, from the research that we've seen, have higher sensitivities and specificities overall. Meniscus, at that point, I would be doing a Thales test at 20 degrees flexion, being very gentle about it, but still doing that position, holding on to them, and then or a modified McMurray's. Personally, I would do a Thales if they were able to take it. Meniscus pain is generally not that significant at the point of injury, but they should be able to do that Thales test relatively easily. Rule out the fracture with the Ottawa Knee Rule. Are they able to weight bear? Can they flex more than 90 degrees? Looking for that palpation over the patella and palpation over the fibular head. And then if you've got a suspicion of the MCL, LCL, the varus and valgus testing. So summary. So from all that, what interests me was the fact that the evidence is really missing for on-field or sideline assessments. We are having to follow data from ED presentations, so people who have gone to emergency departments, acute care clinics, so generally within an hour. At that point there, the knee has swollen if it's an ACL. There is a definite lack of research into that acute on-field injury management. And I'm very passionate about that. Clinicians must step up to drive the research. Imagine how many physios are out there at the moment on the sidelines doing really good work, identifying lesions, helping patients, athletes, etc., with on-field injury management, and we're not collecting that information in research and publishing it to show how good we are, or that what we need to do to identify better clinical conditions to help develop the physios of tomorrow. So my approach to the on-field injury management has been from my experience, but also looking at the evidence associated with it. What I found doing this particularly is don't believe everything you read. Always said that. EBP is about being a critical reader of the evidence. And as you showed there, in a couple of those meta-analyses or systematic reviews, which were done very well, when something doesn't make sense, go back to the primary research. They're all open access, and you can generally get an idea of maybe why the sensitivity and specificity was slightly different. Okay, thank you. Hopefully that was of some value, some interest, and very happy to take any questions that people may have.
Thank you. Thank you, Steve, for such a wonderful presentation today. It was indeed very elaborate, and that's a lot of take-home message. I check if there are any messages there, or somebody who wants to ask me, raise a hand. We have time to take up a couple of questions. So you can just raise your hand and we will request you to unmute and ask your question. Don't see any hand as of now, but
I think they all want to go to their dinner.
it's too early probably for many of us. Yeah? But yes, for you, it's still late. Meantime, if there are none as of now, may I request our president, Professor Savita Ravindran, if she's here, if she would like to.
Sir, can I sneak in with a question, so Zafar here?
Oh, yeah. Oh, we have. Zafar, go ahead.
Yeah. Uh, Good evening, Dr. Steve. Good evening to all the SIP members here. I think it's a wonderful session to begin with on the World Physiotherapy Day and an appropriate platform to exchange such important views about clinical decisions. My take is a little, away from on-field to off-field. And since I juggle between the classroom and the field pretty much, so the concern is that all my novice therapists who are out there learning about ethical decision making and clinical reasoning in the classrooms. The dilemma that we as professors face in the classroom is that their decision making is pretty much having a reductionist view. Whereas when we are on the field, we are primarily, having pattern recognitions that we often practice on the field. So in your experience, Steve, how do you balance these two things together, like on the classroom and in the clinics on the field?
Yeah, and that's a really good point, and that's a real problem we struggle with in that, and because when we do the assessments in the university clinic, we have lots of time, so we can do a whole hypothetical deductive reasoning. We can ask a million questions. We can very much develop hypothesis as we go through, and that's common with difficult scenarios or as part of the learning process. So I think what we're trying to do in the university environment is particularly in the 4-year programs, is to develop them, make sure they spend that time to begin with, but try to work on reducing the time into real world time, which in most clinical practices is 30 minutes in Australia. They have to do the full assessment. The on-field area is just next level because it's brought it down to 5 minutes almost when we're looking at that. And so it really does depend on, I think, focus more on the clinical pattern recognition. We talk about biopsychosocial approach and the need for hypothetical deductive reasoning and slow thinking. Realistically, in the on-field management, our aim of our assessment has to be about safety, patient safety, has to be to make sure that we don't miss something that suggests they shouldn't be on the field. We get them off. So I think our outputs, if you like, from our clinical reasoning are a lot more narrow in sports physio, in that acute on-field management. We're not so worried about narrative reasoning. We're not so worried about all the other things. It really has to be, let's make the decision, can the patient continue on or do they get them off the field? But we don't, then when we do that third one, which is the clinical assessment, that full clinical assessment, then we have that ability to think about the whole patient and that holistic approach and the biopsychology. So I think it's very much, and that's why my model of clinical reasoning, context is really important. Because I see sometimes I've seen some physios, particularly now postgrads that are in the sports course, trying to do full questions to the patient while they're in the middle of the ground lying down. And you go, no, in this environment, we just need to make the decision. Do they keep going or do we get them off? But very good question.
Yeah, that's very true, actually. And that's often the dilemma that we face. You see, there are ethical dilemmas on the field when we are treating a patient. And a lot of it also depends on how much willing is the athlete to go off the field and being treated.
Yeah, and that's why we need to make that call on our clinical reasoning and our objective clinical data, when we do the movement sets, the testing, based on that. Not, I take your board completely, absolutely. Sports can be very tricky because either there's a need for the player to be on or the opposite, the player wants to come off. So for other reasons. So yeah.
Thank you, Dr. for your question, and thank you, Steve, for answering it. We have another delegate, Dr. Viju Thomas, who would like to ask. Dr. Viju, if you would like to start your question by unmuting yourself.
Hi, Nitesh. Good evening.
Hi. Good evening, Viju. Go ahead, please.
Good evening, Steve.
Good evening. Good evening. Hello.
Your presentation was absolutely marvelous. Marvelous. Extremely. The question and the concern that you raised about the sideline assessment, that never happens in India. You don't get a chance. That is why you don't have a clinical research to be done. The moment it is in the field, that sportsman is literally wheeled off for a diagnostic investigation. You don't get a chance to assess. It's not that that you don't have the caliber, you don't have the potential. The mindset over here is that don't put your hands, don't touch, just leave it.
Yeah.
And the maximum thing that you do on the field over here is that rice protocol, cold pack, that's it.
Yeah.
One chance you get is whether you should get him back to play or no. That's that quick reasoning that you were telling.
Yeah.
But the dilemma that we have over here is that we do not have that, that time or that chance to assess them on the field right there to understand, or even I can just tell him that there is a probable injury. What point you emphasis was that when he goes back to play, we have to keep him monitoring.
Yeah.
Whether he may have a potential injury later on if I ask him to play.
Yeah.
Even if I do the taping or strapping or just ask him, now you can go, I don't find that there is much of an injury. That chance is lacking in India.
Okay.
I get these people, you get them after 4 days. I get these people after 4 days going to an orthopedician.
Dr. Vidya, can I interrupt you in between? I mean, we appreciate your sharing, understand. Would you directly come to the question for the Steve so that we have other people also? I'm sorry to say that. We can keep this time for some other discussion. I'm sure Steve will get time to visit us during one of our conferences and we can indulge with it. So can I request you to come to the question directly, please?
The question is, Steve, that when these things happen, how do we, I potentially get somebody after the injury, or maybe there is some physiotherapist amateur at that level who sends him to go and play back, and then he gets back to me after an injury, which could have been avoided at that time.
Yeah, it is very difficult. The context is such an important part of it. If you don't have the ability to access, and I know because you have such access to investigations and imaging, etc., that you do tend to use them quite a bit in India. We tend to, because the cost of them in Australia and particularly the UK, worry about we don't tend to use them as much as such. So it is a completely different context from that side. So, but even with the on-field assessment onto it would be nice to, and I say driven by the clinicians, is to collect data on what you do and the result from it. I think there's so much good work that's done by physios on the field, but we're not seeing it anywhere. It's done in the, I'm passionate about, the problem with researchers is we don't see patients. I'm still a clinician, but researchers work in obscure, we work on obscure things, whereas it'd really be nice to do research on what people actually do. But, I'm not sure if that answers it, but it's, yeah.
Great. No, I'm sure it throws a deeper light, but I think the discussion can go on for hours and hours. Let's, share our experiences and our views and observation about it. But thank you so much, Steve, for summarizing or rather getting so much of detail in such a short span. This gives us a lot of thoughts and a lot of food for thought to think about for our come to as far as clinical practice. I'm very happy to share that we have our president, Professor Savita Ravindran, already joining us. She has been there from the beginning. May I request her if she would like to share something, and thanks the speaker for today. Ma'am, you need to unmute, I think.
At the outset, I want to say a big thank you to you. I was just looking at the time in Tasmania, and it is way past 10:30 in the night. And for you to come on board and be willing to talk to us, very appreciative of that. And Steve, you've always, in your talks, have left a whole lot of questioning for me. I'm not a sports physio, but the take home really is, don't believe the meta-analysis when you see something going a little askew. Really go back to that article. And that's something I'd not thought of, because I kind of blindly believed in meta-analysis and said, okay, that's what they're saying. So they're a little different. Yeah, but that's a very strong saying. EBP is there, but then evidence, take it with a small pinch of salt. Yeah.
I'd have to say the flag for that, if you ever, and I forgot to say this, is when you see a meta-analysis, if you see a random effects model, look further into it. If it's a fixed effects model, it means all the studies are very similar. As soon as you see random, it means there's some studies which are different. And I ask as a clinician, why are they different? The researcher doesn't ask, they just put them in a meta-analysis. But that's why I say, when you see meta-analysis, think from a clinical perspective. Why? I always ask why. And these ones were really interesting because they were just so out of the realm. They should never have been included, but that's a personal opinion.
The second thing I just wanted to say, but I think that US sports physios have such a small time to look at the play of, as you said, the 5 minutes. You know, the window for research, the inclusion and putting the thoughts together. It's a huge plan to be put into place if somebody wants to do it. And maybe that's one of the reasons why it's about going back to the game or not going back to the game. Research takes a backseat of some sorts. I would think like that. I know there are a couple of other questions, and I'm sure people could reach out to you, Steve, but thank you so much. Thank you so much for accepting our offer and coming in, and as usual, very lucid presentation, and thank you.
Thank you for the opportunity. Thank you for the
Thank
invite.
you. Thank you, Steve. Once again, on behalf of entire Society of Indian Physiotherapists and all the viewers and listeners who are hearing it today on Zoom and also on YouTube, thank you so much for your time. It's too late there in Australia, and we look forward to hear you sometime soon and have you in India back soon. Thank you so very much once again. Wish you a good evening and good night, and very happy birthday physiotherapy to each one of you there. I would also like to share another important information for people who are here. Society of Indian Physiotherapists is hosting its 9th annual conference in Vadodara, state of Gujarat. So anybody who's interested can avail the benefit of discounted registration rate by September 10th. So all of you are most welcome to join us in Vadodara, Kala Nagari, Sanskari Nagari in the beautiful state of Gujarat on January 10th to 12th, 2025. Thank you once again. A very happy word physiotherapy to each one of you.
Thank you. Yeah.